Hello everybody and a warm welcome to the Oncomine World Autumn Session for the North American. So I'm Luca Coyata, Head of Medical Affairs for Thermo Fisher Scientific, and once again, given the unprecedented time that we are still living in, we're meeting virtually. On behalf of my Thermo Fisher Scientific colleagues, I want to say that we're very happy to offer you again, one more time, after our Oncomine World Spring Session, another, hopefully, very interesting and valuable agenda. So thank you all very much for joining us. Hope you have seen the welcome message from our Clinical Sequencing Division President, Garrett Hampton. Garrett has condensed all the passion that we have about oncology testing, and he has also shared some of our future plans. So if you didn't have the opportunity yet, you can access Garrett's video message at any time from the lobby. Having said that, I'm very pleased to moderate today's live session, and actually I'm very much looking forward for a very vibrant discussion as we had it in the previous section from the APJ and the EMEA early this morning for me and also at lunchtime for me. And we had very engaging Q&A, and I hope it's going to be the same also this time. We will have also for this time 2 blocks of live presentation divided by breaks, and I will notify you once we're getting closer to the break so that you have the opportunity to go and visit our poster hall, our precision oncology hall. There's a lot of very informative new posters, a lot of data that I hope you will find very useful. But now, let me introduce you the first 2 speakers for today, which are Dr. Carmen Kletecka. She's a medical director from the Molecular Oncology Diagnostics Laboratory at the U.S. Department of Veterans Affairs. She will be talking about molecular testing of non-small cell lung cancer, and she will be sharing what is her experience in the routine molecular testing scenario. And then we'll move forward with the second presentation from Dr. Megan Lin. She's a director of Hematopathology at the University of Pennsylvania, and she'll be sharing with us some data about the clinical impact of next-generation sequencing testing from an hematopathologist perspective. Right after that, we will have our first Q&A section. But now, with no further delay, let's please start with the first presentation. Looking forward to talk to you after that.
Hello, and welcome to the Oncomine World Autumn Virtual Meeting. I'm Carmen Kletecka, Medical Director of the VISN22 Molecular Diagnostics Lab at the Los Angeles VA. And today I will be talking about molecular testing and diagnosis of non-small cell lung cancer biopsies and how to overcome some of the challenges that working with these very small specimens can present. Here are some disclosures. More specifically, I will be going over the clinical guidelines for molecular testing of non-small cell lung cancer specimens, guideline recommendations for biopsy tissue stewardship, and conservation techniques that have worked out well for us. Also, how NGS for molecular testing has been helpful for us at our institution. This is a chart from the most recent NCCN guidelines for non-small cell lung cancer, showing the recommended biomarker testing for advanced or metastatic disease, and also links for treatment algorithms based on the testing results. This chart looks pretty elaborate, but the main point is that the NCCN recommends testing for EGFR mutations, ALK and ROS1 rearrangements, BRAF mutations, MET, exon 14 skipping mutations, RET translocation, and PD-L1 expression. In addition, can also test for NTRK fusions, MET amplification, and HER2 mutations. This may identify an oncogenic driver for which a therapy or clinical trial may be available. The College of American Pathologists, the International Association for the Study of Lung Cancer, and the Association for Molecular Pathology 2018 updated molecular testing guideline recommends testing for EGFR, ALK, and ROS1 at an absolute minimum. And if an expanded panel such as NGS is available, then they recommend additional testing for BRAF, MET, RET, HER2, and KRAS as well. The molecular biomarker testing allows for the identification of mutations that can be used for targeted therapy. And this list here from the NCCN shows several FDA-approved targeted therapy drugs for metastatic non-small cell lung cancer. And this gives the oncologists more options to treat their patients with the ability to apply precision oncology. So for the biopsy, our clinical colleagues go through great lengths to acquire these lung biopsies, and they have to perform complex and procedures that are risky for the patients. These samples also tend to be extremely small. The biopsy shown here is a pretty good size. However, it contains a pretty small tumor content, which is shown in the circled area. And it's not unusual for us to get something like this for molecular testing in the lab. So the laboratory must produce enough slides to perform multiple analyses from the tiny lung biopsies received. The tests that need to be performed include a H&E for morphologic assessment to establish a diagnosis, shown on the upper left. Immunohistochemical stains for further evaluation and classification, and also for a PD-L1 assessment. This is shown in the upper right. And just underneath is FISH analysis, which is used to identify fusions and amplifications. And to the left of that is molecular testing, which is used to identify a variety of genomic alterations. The next logical question for a laboratorian is, how in the world can we do that much with so little? When in reality, the tissue that we received is only enough to make one H&E slide. And oftentimes, this empty block is what we receive in the molecular lab, along with an order for molecular testing. So if you notice, this block contains only wax, and there's no tissue left. So in cases like this, where there is not enough tissue for testing, it is recommended that either a repeat biopsy or liquid testing be performed. This is recommended by both the CAP, IASLC, AMP, and NCCN guidelines. And on a related note, testing rates for recommended biomarkers is not that great, even after all this time that we've been performing them. There was a study presented at ASCO last year showing that a group of patients, 1,200 patients at 5 different hospitals, only about half of them had been tested for EGFR, ALK, ROS1, and PD-L1, and the rate is much lower for the other biomarkers. So the NCCN, CAP, IASLC, and AMP clinical practice guidelines call for the preservation of tissue for molecular testing, and for pathologists to make a diagnosis based on morphology whenever possible, and for the judicious use of immunohistochemistry using only P40 and TTF1 immunohistochemical stains to classify most NSCC cases. And if we follow these recommendations for fostering tissue stewardship, it is possible to turn your molehills into mountains. And a molehill of a biopsy into a mountain of testing results. In our lab, we have implemented the specimen handling protocol shown here. There is no tissue waste. We start by saving the effacement shavings in a vial. And there's a little picture of the vial, and the shavings are represented by the blue lines on the left. The next couple of sections are used for H&E, and 2 is a perfect amount, is exactly what is needed to make the morphologic assessment. No more than that is necessary. The next set of sections are for immunohistochemical stains and PD-L1 analysis. The following set is for molecular testing, and then followed by FISH. And we also have quality control H&E slide cut just before the molecular unstained sections. So by following this protocol, along with the clinical practice guidelines for tissue preservation, we are able to perform all of the required testing for the majority of the non-small cell lung cancer biopsies that are received in our laboratory. We started testing by NGS in February of 2019, and we started with the Myeloid panel. This is a picture of me and a colleague in my lab looking at our NGS system. And right next to that is a press release announcing that in June of this year, we launched the Veteran Solid Tumor Panel, including the non-small cell lung cancer Veterans Mini Panel, which includes BRAF, EGFR, ERBB2, KRAS, HRAS, and NRAS, PIK3A, and AKT1 gene testing. We also provide ALK, ROS1, RET, MET, and NTRK assessment by FISH. In our lab, we test all of the biomarkers that are recommended by NCCN and CAP, IASLC, and AMP, plus some additional biomarkers that have been designated as emerging biomarkers. In general, NGS can be very helpful because it can analyze multiple genes in a single run and requires less DNA than is required for a single gene test. so thereby helping you do more with less. This also helps with turnaround times because you only have to run one test rather than multiple single gene tests, and so you get faster results. This is a sample PDF report for our NGN's Veterans Non-Small Cell Lung Cancer Mini Panel. This is reporting the presence of 2 EGFR mutations. You can see that bolded right at the center. And then just below that, there is a list of therapies and available clinical trials for this patient. This report highlights the importance of establishing a testing process to ensure everyone who needs to be tested is actually being tested, and that their lab results are available for their oncologist to use in making treatment decisions. Testing for all biomarkers improves treatment and overall survival for these patients. So in conclusion, we reviewed the clinical guideline recommendations for molecular testing and biopsy tissue stewardship and looked at how using conservation techniques and NGS for molecular testing can help ensure that there is enough material available to perform all of the necessary testing for non-small cell lung cancer biopsies. Questions?
The title of my presentation is Clinical Impact of Next Generation Sequencing Testing, a Hematopathologist's Perspective. My name is Megan Lim. I'm the Director of the Division of Hematopathology in the Department of Pathology at the University of Pennsylvania in Philadelphia. Here are my disclosures. The outline of the talk today is organized in the following way. I will be introducing very generally the WHO's 2017 classification of myeloid neoplasms. And for this presentation, I'm going to be focusing specifically on the role of the hematopathologist in the diagnostic workup of myeloid neoplasms. The workup of specimens from patients with suspected myeloid neoplasms is very complicated and has a lot of levels of complexity, which I will focus on today, and also to outline some of the limitations of the current workflow that is required in delivering high-quality patient care for accurate and timely diagnosis, subclassification, treatment, and risk stratification. The future perspectives on how today's research breakthroughs with the Oncomine Myeloid Assay GX and the Genexus system could potentially lead to tomorrow's clinical advancements, specifically for triaging suspected myeloid malignancies. The learning objectives for this presentation are to understand the contribution of genetic abnormalities in the diagnostic workup of patients with suspected myeloid neoplasms, to recognize the limitations of the current diagnostic workflow in providing timely integrated genomic results for patients with suspected myeloid neoplasms, and to become familiar with some of the clinical scenarios where rapid integrated next-generation sequencing may facilitate the diagnostic workup of patients with suspected hematologic malignancies. Briefly, myeloid neoplasms represent a highly heterogeneous group of diseases that encompass many different groups of diseases. The diagnostic workup of patients with these disorders is very labor-intense and operationally complex. And in this presentation, we'll be discussing the hematopathologist perspective on the clinical impact of the recent advancements in NGS testing. This slide demonstrates the complexity of the current WHO 2017 classification of myeloid malignancies. As you can see, and many of you are familiar with, I want you to appreciate that many of the specific entities under the rubric of myeloid malignancies are characterized by a diverse group of genetic alterations involving gene rearrangements, mutations, copy number variations. And we recognize today that the contribution of the genetic abnormalities play a critical role in the classification of these myeloid malignancies. In this slide, I will demonstrate that myeloid neoplasms are heterogeneous at many levels, clinically, pathologically, and genetically. Many of these are associated with characteristic and sometimes overlapping genetic alterations, which are increasingly playing a critical role in the diagnosis, subclassification, treatment, and risk stratification of these diseases. The large groups of myeloid neoplasms are composed of the chronic myeloproliferative neoplasms like CML, polycythemia, and others that are defined by either the BCR-ABL rearrangements and mutations involving 3 genes, JAK2, calreticulin, and MPL. Myelodysplastic syndromes also are characterized by mutations in certain genes. MDS, MPN overlapping syndromes also have characteristic gene alterations. Some of them are shared between the myeloproliferative neoplasms and the myelodysplastic syndromes. And then the group of acute myeloid leukemias, many of which are characterized by both fusion genes as well as mutations. Over the last 20 years, through cytogenetic studies, we have learned that specifically in the group of acute myeloid leukemias, that the cytogenetic abnormalities are very important in determining risk stratification. And so we can recognize that there are favorable risk cytogenetics, intermediate risk AMLs, as well as unfavorable risk cytogenetic abnormalities that are identified in acute myeloid leukemias with distinct 5-year overall survival rates. Moreover, in the last 20 years, through many genomic profiling studies, through whole genome sequencing and as well as targeted sequencing studies, have determined that specific mutations in AML contribute to risk stratification. And I show here a landmark study published several years ago indicating that AMLs with mutant CBP alpha have better overall survival than those with mutant NPM1 without FLT3-ITD versus the other genotypes. Genetic alterations in AML are also notable and important for us to identify in a very timely manner because many of them are actionable and affect treatment decisions that have to be made within the first couple of days of the biopsy. And these have made important contributions to improving the patient outcome. Specifically, rearrangements such as PML-RAR alpha, core binding factor, positive AMLs, those that have the BCR-ABL rearrangements are amenable for precision therapies. Also, mutations involving FLT3 as well as IDH1 and IDH2 also need to be identified in a relatively rapid manner to potentially place patients on targeted therapies. In certain contexts, molecular testing is dependent on the core genetic abnormalities, and this requires a triaging of the specimens using the current diagnostic algorithmic approach. For example, once we recognize that patients with a core binding factor positive AML, such as the RUNX1, RUNX1T1 rearrangements or the core binding factor with the MyH11, then we need to identify those that have mutations in receptor tyrosine kinases like KIT and FLT3 because those have specific prognostic information for these patients. In addition, in patients with mixed phenotype acute leukemia, we also need to specifically assess these patients for rearrangements that may provide information about their MLL translocations. In other contexts, patients with AML, other than those with confirmed core binding factor or APL or AML with MDS-related cytogenetic abnormalities, need to be identified because the mutational status of NPM1, DBP alpha, and RUNX1 provides prognostic information for those patients. These are all provided as examples to highlight the importance of recognizing certain disease entities that would allow us to triage or algorithmically test certain disease groups. I've summarized the content of the complexity of the current model of delivery of hematopathology patient care for patients with suspected myeloid neoplasms. You can see that in the initial evaluation of a specimen, bone marrow specimen for patients with suspected myeloid neoplasms, we will start with definitely peripheral blood as well as bone marrow aspirates, a bone marrow core biopsy, and sometimes a cross section. In addition to the morphologic assessment, we do carry out multiple levels of analysis. Usually these are assessing single analytes that can start with the enzyme activity by cytochemistry, followed by flow cytometry-based assessment of the antigens expressed on the cell surface as well as within the cytoplasm through flow cytometry and immunohistochemistry. In addition, cytogenetics through karyotyping and FISH studies are also critical for the workup of many suspected myeloid neoplasms. And then the molecular diagnostic testing also requires multiple platforms to assess usual single analytes requiring many different platforms such as RFLP, RT-PCR, as well as next generation sequencing through either single or panel-based approaches. You can appreciate that this multi-modal, integrative, and iterative process to establish the diagnosis and identify risk predictors and identify therapeutic options and disease monitoring is quite a labor-intensive process that requires a lot of sample material because of the way it is carried out currently. And so in addition to the operational and logistic complexity, there's also the added complexity that each of these testing modalities have variable turnaround times and diagnostic yield, and all of these contribute to results where sometimes we will run out of samples, as well as repeat biopsies from patients of these precious material. So this is a slide to demonstrate the multiple levels of complexity. We need to discuss the specimen quality, space requirements, time of ordering, time of testing, time of result availability, information systems, and personnel coordination in all of these laboratories to coordinate the appropriate and timely testing of all of these analytes. All of these requires multiple levels of coordination and result integration that requires time and before we can deliver accurate and timely information that will impact the delivery of precision oncology. This is a figure to demonstrate some of the logistic complexity and the complicated workflow. Many of these specimens do come to the clinical lab via many different routes. There is a process called triaging where we have to assess the morphologic evaluation of the specimens. Some of them are then processed in the surgical pathology department or division, and then followed by assessment in the Hematopathology laboratory. This highlights that the logistic complexity may result in specimen dispersal and dilution through many different buildings and multiple labs, results in multiple accession numbers given to one patient biopsy material, results in up to 8 modalities of testing with variable specimen needs, with prolonged turnaround times and many, many different hands that are required to go from specimen processing to the final result. This is a slide to summarize the diagnostic work of AML. Again, this highlights the different laboratories and the testing menus and the time turnaround time that is expected for each of these analyte testing. And in some cases, many of these require algorithmic approaches. So, example, if you have a AML with a PNL-RAR alpha, if that is negative, then we have to solicit additional testing for core binding factor. Based on the results of that, we may have to elicit other modalities of testing. And you can appreciate the complexity of, that is required to successfully evaluate bone marrow biopsy for patients with AML for these cases. So the goals of an optimal diagnostic workflow for myeloid neoplasms would be to have a standardized clinical practice where you can have streamlined inter-laboratory logistics. We would like to reduce the time spent for making the triage decisions. We want to improve the turnaround time so that we can initiate the therapy early, ultimately to reduce the hospital stay for our patients, and also to reduce the number of repeat biopsy and testing that is performed. From the technical perspective, the key disease-associated variants that would be important to test for patients with suspected myeloid neoplasms that would be able to capture all of the disease entities that I discussed earlier, including AML, MPN, MDS. These would should be able to identify point mutations, insertions, deletions, translocations, copy number variants, as well as incorporate gene expression profiles, and be able to identify low-frequency alleles. And importantly, for some of the known fusions, we would like to identify both known and novel variants. So this is a summary of the potential implications of having a rapid NGS testing platform for hematopathology. In our laboratory, we have had the opportunity to assess the performance of the Oncomine Myeloid assay, which is able to evaluate all 40 genes that are highly represented in myeloid neoplasms that I discussed, as well as identify 29 fusion driver genes, as well as over 600 fusion isotypes. The advantage of this system is that it's able to analyze all of these genetic alterations that are highly enriched in myeloproliferative neoplasms, myelodysplastic syndromes, MDS-MPN, as well as the acute myeloid leukemias using relatively low sample input at about 20 nanograms of DNA and RNA. This is a DNA-RNA-based panel testing. It is a single platform, and the results are provided within 24 to 48 hours. Our preliminary data indicates that this platform could be highly suitable for two applications. One, to be able to function as an initial molecular screening assay for us to be able to triage bone marrows based on flow cytometry and the rapid NGS panel, to be able to allocate the specimen into these four large categories. The second large application would be in the diagnostic workup of acute myeloid leukemias, to be able to identify both the DNA-based mutations as well as the fusion genes that would be critical for identifying genetic alterations that contribute to diagnosis, as well as identify actionable genetic alterations within a 24-hour time frame, as well as provide information about risk stratification. To summarize, we believe that recent advances in the NGS technology for oncology research are providing great promise for future precision oncology testing. And one example is the Oncomine Myeloid Assay GX on the Ion Torrent Genexus system, which enables robust variant detection and represents an easy-to-use workflow that results or provide results in as short of a time frame as a single day. And these advancements could represent future opportunities for implementing NGS as a first-line strategy for triaging suspected myeloid malignancies. Thank you, and I would be happy to take questions.
And thank you very much to both speakers for their presentation. So both of them very interesting, two different topics, but both of them full of details and very useful information. And now we will move on to the Q&A session. We have a few questions coming from the audience. The first one is it's actually for Carmen, and it's about non-small cell lung cancer testing. So you certainly showed the value of NGS, and given the complexity and the number of biomarkers that need to be tested all at once, there is no longer discussion that NGS should be the preferred method of testing for this patient. However, how do you see let's say, the evolving landscape when it comes to the still eternal battle between single gene testing and NGS? And I am especially referring to the fact that very often, as you mentioned, you're starting from very reduced amount of samples, so very limited amount of samples. Do you think NGS can really make the job, or there is still space for single gene testing?
Well, yes, I think we've shown that NGS has made that jump.
All right. So you would definitely say NGS.
Yeah, absolutely. And we've seen it here in my own laboratory. As we transition from single gene testing to NGS. So I'll give you an example. So initially we used to start with EGFR and BRAF. And you know, those are two separate tests, and they require actually more starting DNA material than what is required for a single NGS panel to test everything. And sometimes we would only have enough to run EGFR and not enough for BRAF. That's one example there. And then also there's the turnaround time. It takes and it's labor intensive, so you got to take that into account as well. So essentially, you're taking all the time and the labor of what you would put into just one test into NGS. If you're doing single gene testing, this could be like multiple days rather than just one day of putting this the sample together for the run. So there's a savings all the way around from DNA material, labor, and turnaround time. So I really don't see this like going backwards to single gene tests.
All right, appreciate. I think, you know, even though sometimes we give it for granted that NGS, you know, is the preferred method, we still see actually, again, some kind of traction and debate about usage of single gene testing, but I think it was very clear from your answer and also from the data that you have shown that, you know, the path is quite well defined in favor of NGS. Thank you very much again for answering the question. And now a question for Dr. Lim. Again, thank you very much for your presentation. You have discussed about the value of turnaround time. Now, I think when it comes to, for example, non-small cell lung cancer patient, I think it's pretty obvious for the majority of people, and it immediately comes up to the scene that we have to be extremely fast because very often those patients are in very late stage of disease. I think sometimes, however, on the other hand, some people are still arguing that maybe in hematological disease, turnaround time is not so critical as for other, you know, solid tumor. I would be happy if you could once again reinforce this concept about the value of turnaround time, if you believe it's actually also a very important point for hematological disease.
Yes, I think the results of molecular testing for acute leukemias have variable significance. So while we can't say diagnosis of AML based on morphology and cytometry, for most of the subtypes, there's information that you can glean from molecular analysis that will definitely aid in initial treatment. So, you know, the acute leukemias with the RA alpha, those need to be tested. Currently, the standard that is rapid FISH testing that requires whole team of individuals, a separate lab, and samples that are required. So if you're able to find or have a DNA assay when you get all of the results the relevant speaking arrangements are used for important AML, that's going to definitely help. Many of the other medical alterations, they provide information about potentially putting patients on clinical trials. And so it's very important to identify those patients early before they get treated with their regular chemotherapy. So I think current standard is that most of the information that is actually made available through genetic testing, if we can get them within 3 to 4 days, it would be have a great clinical impact.
All right, thank you very much. Appreciate a lot your answer. Actually, we have a second question for you. This is a little bit diverging from your presentation in a way that it's asking about the very fast growing need of having MRD solution. So the question more specifically, it's about how do you see the evolution of using NGS and specifically NGS for MRD testing?
I think that is definitely an important area for future investigations. Clearly, as of today, there are not well standardized approaches for MRD for AML. Definitely, there are flow cytometry-based assays as well as some of the acute lymphoblastic leukemias. There are also MRD assays, but clearly there's a lot of opportunities to investigate NGS-based approaches. If we can get the sensitivity to the levels that we are able to obtain that is similar to current methods, and that can be standardized across many laboratories, I think those are the two factors that would have to be demonstrated for this type of application to be widely relevant. I think that is a very big field that needs to be pursued.
All right, thank you very much. Appreciate a lot your answer again. And with this, we actually conclude this Q&A section. Once again, thank you very much to the speaker for their presentation. Also, thank you very much for taking the time for having answered to our question. And now we will have a break of about 20 minutes. So we will be back here for the second part of this event and for another two presentations. Once again, thank you very much to speakers. Thank you very much to the audience for being with us. A pleasure. Join me later, please.